All right, our next chapter is chapter 5, disorders of the ovaries and oviducts. We will start with physiologic enlargement of the ovaries. Functional ovarian cysts. Etiology is an ovarian cyst that arises from a normal physiologic event, but whose size is exaggerated due to inappropriate maturation. A normal physiologic event would be a follicular cyst or a corpus luteum cyst. The appearance is that of a water-filled balloon, thin-walled, fluid-filled, no septations, no calcifications. A simple cyst is the way it appears. And examples: follicular cyst, corpus luteum cyst. The follicular cyst would be in the first half of the cycle, the pre-ovulatory. The post-ovulatory would be a corpus luteum cyst. The management is basically conservative. They will go away on their own. And that is true whether they're large or whether they are small. Now, some people have suggested using oral contraceptive pills. Well, the oral contraceptive pills would have prevented them from developing in the first place, but once they're there, it's just a matter of time and they will involute. The oral contraceptive pills will prevent new ones, but I don't think it does a whole lot for those which are already there. Every woman who ovulates has a dominant follicle, which is up to 3 centimeters in size, such as this one here. You can see it is round, it is smooth, it is well demarcated, it is fluid-filled. You can tell by the dark echolucent area. No septations, no calcifications. This is a benign, simple cyst. Now look at the next one. This is quite a bit bigger. This one is 7.8 centimeters by 11.6 centimeters, but the characteristics are very similar. It is smooth, it is rounded, it is fluid-filled, no septations, no calcifications. This is what it would look like if you took it out, and it does look like a water-filled balloon. Now, I don't know why this one was taken out. It was removed with the ovary and the tube here. Functional cyst. Polycystic ovarian syndrome. This is another physiologic enlargement. This is bilateral. The corpus luteum cyst, the follicular cyst, is typically unilateral. What we have with polycystic ovarian syndrome is bilaterally enlarged ovaries with multiple peripheral cysts. There can be up to 100 in each ovary. This is often described as a necklace of cysts around the periphery of the ovary. Etiology. Because of the increased FSH and LH, in particular the LH stimulates the theca cells to produce androgens. The androgens will increase insulin levels, and the increase in androgens plus increased insulin levels induce arrest of the follicles in these ovaries at various stages of development. So instead of proceeding on to become either a dominant follicle or regressing, they're arrested and they just stay there. So these many arrested follicles, along with stromal hyperplasia and a thickened ovarian capsule, result then in the typically enlarged ovaries of PCOS. What is very interesting is that women who have seizure disorders and who are on valproic acid or valproate have a significantly higher incidence of polycystic ovarian syndrome. And the mechanism is not entirely clear. In terms of the ovaries, you don't need to do anything about them. They don't need to be operated on or removed. Just leave them alone. Here you can see a laparoscopic photograph of these bilaterally enlarged ovaries. Now this is a uterus here, and you can see the ovaries are about the size of the uterus. Here we have the fallopian tube coming down on this side here. The enlarged polycystic ovaries. Notice the necklace of cysts. Now this is an artist's conception here. This is an ultrasound, and you can see all the way around the edge. And these are cysts arrested in various stages of development because of the increased androgens and because of the increased insulin. One of the ways that one treats PCOS, and we'll talk about that later on in the chapter on endocrinology, we will use medications that will increase insulin sensitivity and can decrease then these effects. Again, the ovary, and you can see these multiple peripheral cysts. Ovarian hyperthecosis. This is another physiologic enlargement of the ovary. This refers to nests of luteinized thecocells throughout the ovarian stroma which produce androgens. Remember, it is the granulosa cells that produce estrogens. It is the thecocells which produce the androgens. Now, these are not thecocells in the follicles because many of these women are postmenopausal. They can be in the ovarian stroma and still produce androgens. The clinical features are similar to polycystic ovarian syndrome, only even exaggerated or worse. Many of these women are obese. They have a long history of severe hirsutism, and it may even be virilization. What is interesting is this can be found in postmenopausal women. And you may have heard of the bearded old lady. This is probably what she's got, is ovarian hyperthecosis. Findings: many have severe virilization, clitoral enlargement, temporal balding, deepening voice, and male appearing hair pattern. Now, this is different than hirsutism. Hirsutism does not have enlargement of the clitoris, does not have temporal balding, deepening of the voice. This is virilization, and this is going to be from high levels of peripheral androgens. Most will have amenorrhea, particularly those who are premenopausal. Some have acanthosis nigricans, and the acanthosis nigricans seems to be a marker of insulin resistance. I'll show you a picture of that when we discuss this further in the section on PCOS. The mechanism: increased ovarian androgens, stimulate increased peripheral estrogens, and remember, all estrogens are derived biochemically from androgens. These increased peripheral estrogens can then increase the risk of endometrial hyperplasia and cancer. How does one manage this? The oral contraceptive pills can be very helpful in two ways. Oral contraceptive pills will suppress LH along with FSH. And when the LH levels fall, the stimulation of the thecocells is reduced, and so the androgen production goes down. So we have decreased peripheral androgens by suppression of the thecocells, by decreased LH. The other thing is that as we decrease the free androgens, the sex hormone binding globulin is raised by the estrogen in the oral contraceptive pills. And as you increase the sex hormone binding globulin, the free androgens decrease. So we have a decrease in production of androgens, and we have an increase in the binding, both of these which lead to then decreased peripheral androgens. This is a gross section of an ovary showing these multiple areas of nests of thecocells in the ovarian stroma which produce the androgens. Luteomas of pregnancy are physiologic enlargements, and these are bilateral. They are rare, non-neoplastic tumors. That's non-neoplastic, they will not become cancerous. And they are tumor-like masses of the ovary that emerge during pregnancy, regress spontaneously, and you don't need to do anything about them. They are bilateral, they're asymptomatic, they're found incidentally during a cesarean section, and they can be hormonally active, producing androgens, resulting, interestingly, in maternal and fetal hirsutism and virilization. So if you have a female fetus exposed to high levels of intrauterine androgens, you could have virilization. And this is a patient that I had. and we did a cesarean. This is the post-cesarean enlarged uterus. And here we have these bilateral ovaries. Looks like kind of tapioca, these small cysts. This is omentum. Just leave it alone, and they will involute on their own. Luteomas of pregnancy. Okay, the last physiologic enlargement of the ovaries we'll talk about is theca lutein cysts. These are also benign, but they are stimulated by high levels of FSH and HCG. Because these high levels can stimulate the ovaries, we would think that you would have this whenever you have increased levels of HCG. And twins, you have two placentas which are producing HCG. And molar pregnancy, of course, we have trophoblastic disease with very high levels. So these theca lutein cysts are seen very commonly with twins and with molar pregnancy. They will spontaneously regress as the HCG levels come down. The FSH levels used in stimulation of ovulation in infertility can result in these theca lutein cysts as well. The management is conservative. Don't take them out. Leave them alone, and they will regress on their own. And here you can see how huge these ovaries can become. Theca lutein cysts, bilateral, leave them alone. This is a patient that I had, and I did an ultrasound on the ovaries, and you can see some of these ovaries are 16 centimeters in length, 7 centimeters in width, and each of these follicles can be 5 to 6 centimeters in size, these cystic areas. All right, that's the end of physiologic enlargement of the ovaries.